During pre-oxygenation, essentially what we want to do is BiPAP, but once we paralyze the patient, what we're going to want to do is have them on a rate. But we don't want to have to toggle between modes in the interim there. So the way we're going to do BiPAP during pre-oxygenation is we're going to use the SIMV mode as opposed to the non-invasive positive pressure ventilation mode. We're going to put the SIMV mode at a rate of 0. And with a PEEP of 5 and a pressure support of 10, we will therefore be doing BiPAP. SIMV at a rate of 0 with those settings is essentially BiPAP. We're going to dial the flow down from the baseline, which is usually set at 60 liters per minute, down to 30, and we're going to do that because we want to minimize the chance that we are going to overcome the esophageal sphincter and insufflate the stomach. And we're going to go on the high end of a lung protective tidal volume at 8 cc's per kilogram of ideal body weight because we do want to maintain as much minute ventilation as possible. Of course, we're going to have the FiO2 set at 100%. Once we've done that, and we've got the patient pre-oxygenated, we're going to go ahead and induce and paralyze the patient. And we're looking at our watch. For sucks, it's 45 seconds, and for rock, it's 60 seconds. During that period of time, when the patient would otherwise be apneic, again, of course, they cannot afford to be apneic because that's going to add respiratory acidosis to their severe metabolic acidosis and push that pH lower into the cardiac arrest range. So we are going to push that respiratory rate on the SIMV up to 12. We don't need to push it all the way up to 30 or 40 as the patient was breathing spontaneously for that 45 to 60 seconds. 12 is going to be enough to keep that pH where it needs to be for that period of time. And then once the apneic time has elapsed, we go ahead and do our laryngoscopy. We've got the patient maximally positioned, and ideally we nail that intubation very quickly on the first attempt, and we confirm with waveform capnography that we're in, and then we put them on the vent and we increase that respiratory rate up to 30, and we increase the flow rate back to 60 liters per minute. By doing this, we hopefully are maintaining enough minute ventilation to avoid the addition of any respiratory acidosis to the patient's severe metabolic acidosis. And we are going to watch their end-tidal CO2 like a hawk. It's going to be low, and that's essentially good, and we want to keep it low. We don't want to let that end-tidal increase at all, because if that end-tidal is increasing, in all likelihood that pH is dropping. And so we just want to keep that end-tidal low where it is until we can get ourselves a blood gas and find out exactly where we really are on the pH. If you think about things in terms of minute volume, for you and I right now, non-intubated, to maintain eucapnia, we need to breathe about 60 cc's per kilogram per minute. If we were intubated, to maintain eucapnia, we would need to double that to 120 cc's per kilo per minute because of the additional dead space of the circuit. But if what we're trying to do is to cut our PCO2 in half, then we would actually need to increase it or double it again up to 240 cc's per kilo per minute, which at an 8 cc per kilo tidal volume and times a respiratory rate of 30, that's going to get us to 240. This is not the sort of case to have the medical student get a try at the intubation. That's just not fair to the patient. I love medical students, but a case like this, where the patient's very life is on the line, and they're starting from 6.85, we need to have the most experienced operator do this intubation and get it very quickly. And again, the end-tidal CO2 is something we're going to need to watch like a hawk. Capnography, until we can get a blood gas, is the key to making sure we keep this patient alive and avoid peri-intubation morbidity or mortality or cardiac arrest. We got to keep that end-tidal CO2 low where it is until we can get a blood gas. And if at all possible, we want to avoid reparalyzing these patients after the initial RSI because it can be very beneficial to them to regain the ability to breathe and control their minute ventilation. Their brain knows where they need to be to maintain their pH at a safe level. So avoid paralysis if at all possible. So getting back to the case, we go ahead and position the patient optimally so that we can nail the intubation on the first attempt. And we decide we're going to use the ventilator strategy. So we've got them very well pre-oxygenated. We use SIMV at a rate of 0 to do that pre-oxygenation at essentially doing BiPAP. And then once we push our induction and our paralytic agent, we increase that rate up to 12. So that Untitled stays rock solid right where it is, which we know in real time during the RSI because we've got a capnography cannula to do our apneic oxygenation. And it's not rising at all because we don't let them be apneic. Other than for the approximately 15 seconds it takes the most experienced operator to nail that intubation on the first attempt. We confirm the intubation with waveform capnography, which is again right where it was before, nice and low, and we ramp that rate on the ventilator up to 30, and at that point we avoid reparalyzing the patient and we keep their end-tidal CO2 right where it is, nice and low, because if it's rising, the pH is falling, until we can get ourselves a blood gas, which when we finally get one, we find that the pH is actually improved through the whole process, and it's up to 6.98. So the patient is still incredibly sick, but they are better off than they were beforehand, and now we've got a secured, protected airway. So congratulations, strong work. So let's review what we've learned. Fifth case, summary case. You get called out again to the emergency department of a small rural hospital for a patient who comes in with fever, shortness of breath, delirium. He's got a lobar pneumonia. He's got septic shock. That's his chest x-ray. And upon your arrival, you find the patient somewhat combative, in severe respiratory distress. He's tachypnic, he's retracting, he's cool, diaphoretic, he's delirious. Thankfully, anatomically, he's got no lemons. He's a pretty normal patient anatomically. But his vital signs suck. Hypotensive to 74/47. He's in sinus tachycardia at 116, tachypnic to 35. He keeps pulling his non-rebreather off, so he's 72% on part-time non-rebreather. And the outside emergency department got a VBG, and he does have a pretty significant metabolic acidosis, pH of 6.95, PCO2 of 28. And in all likelihood, that metabolic acidosis is coming from his lactate of 8. So this guy is sick. So what's his problem? Is it the H, is it the O, or is it the P? You got it. He's got all three. Thankfully, he at least doesn't have difficult anatomy to go along with that. So let's think about how we're going to manage this patient, because any one of those three would be enough to make this intubation perilous, and yet all three of them together is a recipe for disaster. That being said, you're 40 minutes away at this outside ED from the medical ICU at the tertiary center where he's going. And I don't think anybody in their right mind would think that the best thing for him would be to remain unintubated. Because as risky as the intubation is, transporting him unintubated is probably even riskier. So let's think about logically, in a regimented fashion, how we can minimize his physiologic peril from all three of these problems. The first thing I'm thinking that I would do for this guy, who is resisting any effort that I do to stabilize any of these things, is to stabilize the situation with a dose of ketamine. He keeps pulling his mask off. If I try and take a look at his upper extremity to try and get some good peripheral access, he's fighting me on that. And it's going to continue to be a cluster if I don't control his delirium and his combativeness. So I'm thinking I would go off the bat with a dose of ketamine for the purpose of doing DSI and everything else that I need to do to stabilize him. So that would be one of my first interventions. I would make sure that that non-rebreather is cranked up such that the ball on the regulator is bouncing off the top of the regulator so that he's maximizing his FiO2. And it's possible that that may be enough, along with repositioning and elevating the head of the bed, to fix his oxygenation problem. But after I give him ketamine and I crank that flow rate on that non-rebreather all the way up and I give him a couple minutes, I find out that I've only improved his oxygenation up to about 90% on that non-rebreather. That's a lot better than 72, but I can't be satisfied at 90% without trying some positive pressure ventilation. So at this point in time, I'm going to go ahead and work on getting this gentleman on the ventilator on non-invasive positive pressure ventilation. And because I know that I'm going to want to switch it during the apneic period, once we do RSI, to a rate, I'm going to go ahead and do that BiPAP essentially by SIMV at a rate of 0. Alright, meanwhile, we need to work on his hemodynamics, because they kind of suck and they're about to suck more once we add positive pressure ventilation. Thankfully, he's in sinus rhythm, so at least we don't have a rhythm issue to deal with. We need to make sure we're maximizing his preload, and he has ripped out the only 22 gauge peripheral IV he had, so he's got nothing, and you see nothing. So, are you going to spend the next 15 to 20 minutes putting in a central line in this guy? Heck no. You're going to go to the IO. And now that you've got his behavior controlled, minimizing the chance of displacement, I would go straight to the humeral site because of the 5 times greater flow rate there as opposed to tibial. And given that, with a pressure bag, we can very quickly get in a significant volume of crystalloid to help to maximize his preload. Another thing to think about with this guy would be a push dose pressor to try and stabilize those hemodynamics because of the physiologic peril that he is in, which is about to get worse once you induce and paralyze him. So again, I think phenylephrine is the clear winner over epinephrine in this case because of the tachycardia that he's starting with, and I would go ahead and get a push dose of phenylephrine on board with this guy. And I would think about getting a drip ready of norepinephrine as well. You also notice as you thumb through the outside hospital's labs that they have back that he is somewhat hypocalcemic. He's down around 8.2, and that hypocalcemia is not helping out his inotropy any. So giving him a dose of calcium may help out your hemodynamics by improving his inotropy as well. Okay, so we've dealt with the hemodynamics, and let's say we've got his blood pressure up to 88/60 at this point. It's not great, but we've improved things quite a bit. We're doing everything we can for oxygenation, and now that we have him on non-invasive positive pressure ventilation, which is essentially BiPAP, done via the route of SIMV at a rate of 0, we've got his pulse ox up to 96% on room air where it plateaus. So we've done an excellent job of stabilizing the situation from an oxygenation standpoint. So we've dealt with the H, we've dealt with the O, and then the final issue is the P. And again, what we can't afford to do is to add any respiratory acidosis to his metabolic acidosis. So once we go ahead and do our RSI, which we've already given ketamine, so the induction is done. The paralytic, a reasonable person could choose either sucks or rock, and I'm not going to get into that debate again. But once we push that 45 to 60 seconds that would otherwise be apneic time, we're not going to allow to be apneic because we're going to increase the rate on the ventilator up to 12, and he's going to get 12 breaths over that minute. And that's going to be enough to avoid having his pH drop anymore. Of course, we're doing apneic oxygenation with a nasal cannula that can also double as a capnography device during the laryngoscopy. We're going to have the most experienced operator do the intubation. And amazingly, despite the physiologic peril that this guy was in that was coming at him from all sides, we get this guy intubated on the first attempt without any hypoxia. His hemodynamics don't worsen, and his pH doesn't worsen. And once we get him intubated, we put him on the vent at a respiratory rate of 30. We use a lung protective strategy. We keep an eagle eye on that waveform capnography to make sure that until we get a blood gas that it's not increasing any, because if that end tidal is increasing, his pH in all likelihood is decreasing. And we deliver this guy to the medical ICU at the tertiary center in a much more stable situation than what we found him in. The other point I would make is that there is no way that I would leave that referring emergency department without getting bug juice on board. We want gorilla coursing through this man's veins. Because once we get his airway established and we've done what we can to stabilize his hemodynamics and his pH, there's nothing left for this guy that is time dependent other than time to antibiotics. So if he has not already received them, and if I don't carry them myself in my transport vehicle, then I'm not leaving that referring ER until I get my hands on something so that I can get that started en route, as opposed to waiting till he gets to the accepting hospital to get those antibiotics. Excellent job stabilizing that man on that case. That was incredibly tough. So, I would posit that we cannot manage what we cannot measure. What most people are measuring in terms of a metric of airway management success is first attempt success rate. And obviously, first attempt success is great, but it's not enough. And if that's all that you are measuring, then you are thereby essentially incentivizing people to potentially continue laryngoscopy attempts beyond when they should, because they get onto the steep portion of the oxyhemoglobin dissociation curve. And there's no incentive to think about things like severe metabolic acidosis or severe hypotension that you could do something about to stabilize. So what we're doing with AirCare here in Cincinnati is we are measuring something called DASH1A, and that stands for definitive airway, sans hypoxia, or hypotension on the first attempt. This is a rigorous metric, and it is somewhat difficult to measure. But that being said, I do think that it's a much better measurement of true airway management success than the tried and true first attempt success rate. Churchill said, "Never give up. Never, ever, ever give up." And as resuscitationists, no matter how bleak the patient's physiology looks, no matter how difficult the anatomy, we have tools in our toolbox to deal with these things, and we need to be ready to use them. So don't give up. Thank you very much for listening. It's been a pleasure to discuss this topic, and I'd be happy to discuss it with any of you further via these methods. Thanks a lot.